We'll move on to the next speaker. We will have the next talk by Dr. Rakhi Kusumesh, and she will deliver the talk Grafts and Glues in Ocular Disorder. Over to you, Dr. Rakhi Kusumesh.
Yeah, good afternoon, everyone. My topic is actually graft and glues in ocular disorder, but no, this is since this topic is very large and cannot be covered in a 7 minutes, so I would limit my talk to role of graft and glues in restoring ocular integrity. So the most common corneal emergency what we face is corneal perforation or impending perforation or desmatoseals. So first objective that we should look at is to restore the globe integrity in these cases, and there are several management present for managing these corneal emergency cases like suturing to adhesives, amniotic membrane, Tenon's patch, corneal transplantation, and other different types of grafts. Majority of my cases were done in COVID pandemic. So coming to glues first, there are two type of glues available, like synthetic and biological. Synthetic one is easily available and it is very less expensive and easy to use, but it has a high tensile strength and it is not biodegradable. So it has to be used for external surfaces only, not for the intraocular purposes, and the most common indication is corneal perforation. On the contrary, biological glues are expensive, they require reconstitution, and they are of low tensile strength, so they cannot be used as sealant, rather it has to be used as adhesive in all the cases, and it is biodegradable, and the most common indication like an amniotic membrane or others. So this is the way how we prepare the cyanoacrylate glue. It has to be just, we need to load, while in fibrin glue we have to reconstitute the fibrin and thrombin. Now we don't have that thermostat for the preparation of glues. So there are several techniques available for application of cyanoacrylate. Now my preferred technique is to use the back handle of Marocell sponge, which gives a very thin and fine layer of glue over the operating sites. So these are a few videos, like one is the fungi, dementatious fungi, where we are taking biopsy in the same sitting, as well as putting the glue in the weaker side as well as at the site of perforation. Second one is in the vitrectomized eyes where the cornea fistula was there, so we have to de-epithelize the tract completely before applying the glue. So just I'm sharing few tips for corneal gluing. One is to always remove the necrotic tissue and mucus before application, and de-epithelize the surrounding area as well as the site of perforation. Dry the surface completely before application and apply only a thin layer of glue. Don't heap the glue over there. And check the glue before applying BCL. Sometimes BCL is stuck with the glue. Second one is amniotic membrane graft. This is one thing that we cannot think of any ocular reconstructive surgery or any ocular surface surgery without this membrane. This is a biological membrane which has no immunogenicity, and it has both mechanical and physiological barrier. It has several properties like epithelization, anti-angiogenic, anti-inflammatory, and antimicrobial. So there are various techniques available for AMG application. One is the graft or inlay technique. It is used where the tissue loss is present because it actually replaces the volume loss. And second one is the patch or overlay technique, where the epithelial lining is downwards and it acts as a biological contact lens. And the third one is layered or filling technique, where both the overlay and inlay used. So it all depends upon the size of perforation or impending perforation for the technique. So here I'm sharing one case. This is a case of perforated PUK, and in this multi-layered amniotic membrane was applied, and it was secured with the cyanoacrylate as well as the sutures. So after 3 months, patient had good strength in the periphery. All reaction were under control, and here you can see in ASOCT there was a good thickness of amniotic membrane after 3 months. So now this patient is waiting for optical PK. I think it has been done because of steep cornea and high astigmatism. So this is a second case. He has a case. He was under tuberculosis treatment. He was taking ATT, and he had a rapid this necrolysis of the cornea and the periphery. And so we did amniotic membrane grafting in this case, and that gives a very good sealing at that part. And ASOCT also showed a good results in this. So another application, like in cases of SJS, where we need to do take care of perforation, sterile perforation in these cases, and sometimes in infective keratitis, basically in the viral keratitis, not for other suppurative keratitis. So AMG is a safer method to restore ocular integrity in perforation or impending perforation, particularly in cases where the donor cornea is not readily available. Then the Tenon's patch graft, I would say this graft was savior in COVID pandemic, and it has many advantages, like it is autologous and there are less chances of autoimmune reaction, and it is economically very viable option. Disadvantages, it doesn't give any kind of vision improvement because it's an opaque tissue and it has a low tensile strength. So this was a case of a 43-year-old man who came to us in COVID, and he had recurrent episodes of stromal viral keratitis, and he had a big perforation at that time. So we didn't have cornea, and for tissue adhesive it was very large with iris prolapse, and amniotic membrane was not available to us. So we planned for Tenon's patch graft, and after patch graft in 3 weeks the graft vascularized and epithelialized. Then we removed the suture, and then afterwards when cornea became available to us, we did optical PK as well. So harvesting a Tenon's graft can be harvested very easily from the superior nasal or superior temporal quadrant, and it can be secured with the fibrin glue because it's a very sticky tissue. To better apply 1 drop of glue and then put the Tenon's graft, and it can be secured with overlay sutures. And suture removal is also very easy in these cases, usually after complete epithelialization and vascularization of the graft. So there are few modifications are also documented in the literature with Tenon's patch graft. Here we publish a report in IGO. This was an original article. Apart from seeing the efficacy, we also looked at the predictors for successful outcome, and we found that desmatoseals gives good result in comparison to perforation, non-infective, better than infective. And among infective keratitis, viral keratitis were the good cases who gave good results, and paracentral and peripheral perforation we found better results. Last, this is a patch graft when you have
Dr.
cornea and
Rakhi,
you have to
Can you just
yeah.
Okay, thank you.
We have to do multiple procedure at same time, then better to go for corneal transplantation. So this is a flow chart. This is how I manage my cases. If the patient comes with corneal perforation with no tissue loss, corneal suturing should be done. If patient comes with tissue loss and if the perforation is less than 2 or less than 3 without any incarcerated uveal tissue, then cyanoacrylate glue is best. And if there is incarcerated uveal tissue, you can go for Tenon's patch graft or amniotic patch graft. And if the perforation size is more than 3 and donor cornea is available, better to go for patch graft in the peripheral lesion or tectonic PK for the central lesions. And if it is not available, then up to 6 or 5, we can go for the Tenon's patch graft or amniotic with or without cyanoacrylate glue. Thank you so much.
Thank you. A very nice collection of videos and photographs. Nice presentation. Thank you.
Thank you so much.